Doulas play a big role, but I do see that even postpartum doulas sometimes don't have a lot of leverage. But as
Mm-hmm.
rehab providers, we're typically the people that see them first. I can't tell you how many times I have picked up postpartum depression and postpartum anxiety. And unfortunately, I've had even a recent case of postpartum psychosis, right,
Mm-hmm.
in Black women.
Mm-hmm.
They're coming to see me because they trust Dr. Yeni and they know that she's going to keep it real. And I'm like, you, friend, I will say it to my friend, something's off about you. Is your mom here? Can she take the baby? Because I need you to go get some help. I'm going to have you go to the ER right now, right? And she's like,
Yeah.
oh, it's too much. I'm like, trust me. Something in my gut saying that something about it. Sure enough.
Welcome back, everyone, to the Integrative Women's Health Podcast. I'm your host, Dr. Jessica Drummond, and I'm here today with Dr. Yeni Abraham. And I'm so excited to introduce you to her. We met almost 6 months ago in Georgia at the Pelvicon conference, which we were both speaking there, and she really gave an innovative talk, as we're always looking for on this podcast in our community. And today we're going to dive deep into the story behind her professional journey, what she's doing to innovate the field of fertility education and pelvic rehab, and how we can help all of us as women's and pelvic health clinicians do everything we can to improve the really severe Black maternal health crisis that's going on within our health system. So welcome, Dr. Yeni, and I would love to hear a bit of your story. What brought you here?
Well, thank you so much for having me. And yeah, I can't believe it was that long ago that we met. It seems like it was a little bit longer ago. I don't know what it was, but
Yeah.
yeah. So I am so happy to just chat a bit about my journey. I think when I tell this story, I've told it in different perspectives, but I think the perspective that speaks to me more recently is just leaning into how my personal and professional, lives collided,
Mhm.
because sometimes as clinicians, we don't necessarily start the work and then find ourselves personally dealing with the same challenges. Sometimes it's the reverse. I find that a lot of clinicians are inspired by their own journeys and then get into the work. But I'd say that for me, I came out of physical therapy school pretty certain that I wanted to be a pelvic floor therapist. And so from day one, my first job was in pelvic floor therapy. And I saw all genders, multiple different ages, and I got a real gamut of it. And after a couple months in, I would have these coincidental situations where I'd have patients who would return back to me and say, my period was a lot better last month, or, I felt like I slept a lot better. And I'm like, what? And if you've ever worked in outpatient orthopedic physical therapy settings, you hear your typical, yeah, my knees moving better, I'm running better, my balance is better, but you don't always hear somebody tell you that their period was better, right? So,
Mhm.
of course, that was a bit of an anomaly for me, and it created a sense of curiosity. I think I use the word curiosity quite a bit now when I explain my story, because that's literally what I led with, is curiosity. I never claimed to be an expert in anything, really, especially early on in my career. I didn't know, I barely knew what one joint was from the other early on, right?
Right. Yeah.
But I led with that curiosity, and just because that curiosity created opportunities for me to start taking different Con Ed courses that would actually place what were accidental manual skills into a frame of reference for me. And
Mhm.
so I'll backtrack and say this. I don't, I was reflecting the other day, and I was thinking, where did I get my confidence and my manual skills from? Like, where did this start? And it started I had an amazing advisor and instructor when I was in physical therapy school, Dr. John Winslow, who gave me an incredible confidence in my manual skills. He taught me how to trust my hands. He taught me how to trust my instinct. And I'm so happy that I learned that level of advanced skills so early on, because it carried me along, right? And
Mhm.
so, like I said, I started, the first was just, why are my patients' periods getting better? Taking visceral courses to establish the why, and
Mhm.
then realizing that, well, if I could fix their periods, then surely there must be a way to also manage ovulation, right? And then started having a couple of patients, typically with PCOS, who would have fibroids, who would come see me, who maybe have had to have like insidious like groin pain, just interesting MSK injuries. And we were able to create systems and techniques that I was able to implement on them, and we were achieving positive pregnancy results. And so there's a much longer version of this story, but I like to highlight this because at this point, I started also going through my own fertility journey. And it was kind of like when art imitated life. Like I was a person that was obviously making all these like interesting findings. And at that time, I wasn't talking a ton about it. I think only a handful of my colleagues really knew the work I was doing in my office. I mean, I think at the time I maybe had like just connected with Nicole Cozine, and she was like, "Oh my God, you gotta teach people what you're doing." And I was like,
Yeah.
"Teach people? I just figured out what I'm doing, right?"
Yeah.
But just to cut the long story short, having my personal infertility journey did awaken a sense of purpose in all of this work and created just a bit more gusto, and not just doing the manual skills, but also learning the wellness component, the nutrition component, the hormonal, component, and really treating people holistically, literally the whole body approach.
Yeah, that really mirrors a very similar experience that I had where I was sort of optimizing my hormonal health and then my pelvic pain patients. I thought, well, if we can truly improve hormonal health with nutrition and mindfulness and all of the, supplements, why couldn't we improve pelvic pain? Because there's such a hormonal component. So I think that's really what we want to be doing as a profession and innovating by catching a thread and then seeing people. I had a patient who was like, "Oh my gosh, I stopped eating gluten and dairy and I didn't have to have a hysterectomy." Obviously, that wasn't the whole story. It's not that simple for most people, but I'm sure you've seen those aha cases where it's like, "Oh, I, improved the fascial flow in this certain part of the abdominal pelvic region and suddenly, oh, we're getting circulation and lymph flow and nervous system connection, and now this person can get pregnant." So I think we're just starting, as even within integrative and functional medicine, to truly understand how important that flow of fascia and lymph and really superficial nerves and capillaries, that's truly a part of the neuroimmune system. I've been talking, well, to other people, and I've got more and more of a heavy caseload of complex chronic illness with a lot of like viral reactivations and endometriosis and chronic pain. And I think we're now seeing this connection between, mind body medicine used to be very separate in the sense of you were meditating or
Yes.
you were exercising.
Yes. Yeah,
But
or you use holistic medicine versus conventional medicine. Yeah, absolutely. It's definitely, I think people are starting to realize that it is a healthy balance of both. Absolutely.
well, and I think even more than that, the connection space physiologically is in that sort of fascial lymph, superficial capillaries, nerves space that people that are well trained, not even, I don't know if well trained is even the right word. Trained is part of it, but as you said, have that trust in their hands. They almost have the ability to listen with their hands.
Yeah, exactly. And of course, Jean Barral, who's like the master of visceral manipulation, that's the technique that he teaches is local listening. It's an intuitive way of passively testing and appreciating value beneath the skin, beneath the dermal layers. And of course, these are manual skills that we're referring to. And again, it takes, I think, what I've learned to appreciate over the years is how some people's natural tendencies as providers is going to lead them to learn these skills a lot easier,
Mm-hmm.
right?
Mm-hmm.
Because if you're already pretty intuitive as a provider, if you're not married to the research and you're willing to take risks, you're going to find that you're going to make a lot of impact in the fertility world, right? But if you're always looking to check off boxes, I mean, someone who is dealing with unexplained infertility is not in the same kind of very, very squared box as someone who had an ACL reconstruction, right? Doesn't mean that
Right.
there's not nuances to that reconstruction, but there's a bit more predictability when we see challenges arise.
Well, and the reality is we also have more research on things like sports injuries, so we can
Yes.
develop protocols, whereas what you're doing is innovating the protocols
Yeah.
of fertility, which it's not to say that anyone, there's not a one size fits all protocol for anything. But I think what you've created here around fertility and manual therapy is the, you know, I don't know, 1980 version of maybe even later than that, like 90, if I think about when I graduated from school, like in 1999, even we didn't have as clear of an ACL recovery structure as we do now. So,
Exactly.
so what you're creating is really that. So let's talk about that a little bit. Like in the experience that you have now and some of the feedback you've gotten from your patients and your own experience with infertility and then pregnancy, let's say we're in that early stage of framework that we would eventually be able to test. What does that look like for you?
Yeah. So if I understand your question correctly, we're kind of looking at, all right, so if we have a particular diagnostic issue, PCOS or endo, that potentially is impacting fertility outcomes, like what are the sequencing that we're doing, right?
Mm-hmm.
And the funny things, Jessica, I have learned the more I try to sequence it, the less it needs to be sequenced.
Good, good.
Because it's not when I'm telling you, reproductive health is the wild, wild west. It is. You cannot you cannot protocol this. You must
Mm.
be willing to curate it.
Mm.
And I think a lot of providers struggle, especially people who are I'm teaching a cohort of providers right now who are getting certified. And a lot of the initial learning is unlearning systems that told you have to do things one way, because
Mm.
you're going to meet 10 patients on your caseload at the same time who all have PCOS, and they're all going to be uniquely different, and they're
Yeah.
all going to have infertility. So how do you approach this, right? And why is it that when you did something on this patient, it worked right away, and then you did the same thing on another patient, and you're still feeling like you don't know what the heck is going on? It's because, like you said, we are complex beings, right? We have hormonal receptors and response patterns in our body. We have genetic findings. I mean, if you want to be wowed and you ever want, some quote unquote light reading, be sure to pay attention to all the genealogy and genetic work that's happening right now, because we're constantly learning more about. Even the other day, I was looking at some work that they had looked at some archaeologists had dug up some old bones, and
Mm.
I mean we're talking about like thousands of years old, and we're able to pick up so much information about some diseases that even existed back then that we haven't had a lot of conclusions about. So things are always changing, right? So
Yeah.
I am not, and if and who knows, maybe 20 years from now, my thought pattern around this is going to be different. But I just don't think it is safe enough and it is wise enough to teach people a protocol when you are approaching reproductive care.
Yeah. Well, and I also think that in doing work with hormonal regulation and nervous system regulation is what I've been doing for 17-ish years now. Eventually you're able to sort of come up with an order of
Yeah,
operations, if
yeah.
you will. And I think that's the closest I've ever come. And
That sounds about right.
yeah.
Like you kind of know what areas you want to hit, right? And you kind of know, like, okay, for the most part, this should work for you. But
Yeah.
I always leave things to chance. There's a likelihood that, I'm gonna give this person all this education and they're gonna get all this feedback, and then they're still gonna come away and say nothing changed, right? Those things do happen, right? But I think as far as when it comes to especially individuals who are on early on in their careers, or not necessarily early on, who are looking to refine certain skill sets around reproductive care, I don't like to teach a protocol, right?
Yeah.
I think that it does more harm than good, because when people don't fit in the box, there's a ton of frustration, and then and providers are. Let me tell you right now, like I tell all my students, you are not there to fix your patients. There's no such thing, right?
Yeah.
Because fixing, so saying that you're fixing a problem or fixing them is saying that they're broken, right? And that's not fair. So
Yeah.
I think we have to give people the benefit of the doubt that there might be some dysfunction there. Yes, there can be, some impairments there, things that definitely need to be corrected, or dysregulation. That's common, in the work we do. But we don't come in guns a blazing with a cape on and say, hey, abracadabra, let me fix you.
Yeah. Absolutely. So in the work, are you doing in your manual work? Is it full body? Is it, because I'm thinking kind of cranial vagus nerve, pelvic floor, spine, feet. Like, how do you begin to approach this what are you looking for first with a client?
So great. I'm happy you phrased it that way because I'm not looking. I
You're
am
listening.
I'm listening
Mhm.
exactly. I'm there to receive the information that is present. And so, of course, the zone of operation is typically in the abdominal pelvic space. That's where
Mhm.
I hope to get enough information so I know where to go, right?
Mhm.
And typically, my assessment of the abdominal pelvic region, whether it be internal with pelvic floor findings or I'm looking to do my visceral skills there and do some local listening, what I'm looking to do is just say, okay, where does it seem like we should go, right? If there are old scars and if there's adhesions, okay, then of course we're probably going to do a ton of fascial work as well. And I'm going to be, of course, if there's like neuromuscular problems, I might have, them doing some PNF movements,
Mhm.
bringing those things back up. If there's a lot of hormonal migraines or trauma involved, we're going to do some craniosacral work. We're going to do some vagal nerve work as well. And of course, and this is one thing I tell my patients is like, I go where your body tells me, right? I
Mhm.
go where I feel led. And of course, if they feel, and I've never had a patient that's had issues with this, but I always lend them to some level of descriptive explanation because I want them to feel affirmed
Mm.
in the things that they're feeling, right? Like if I'm going there and I feel an existential amount of discomfort or someone has an emotional letdown, the idea is we're going to come and we're going to talk about it and we're going to say why did that potentially happen or what were you feeling when that happened. But then I'm also going to let them know that hey, your body is telling us, is calling attention to this area, and that is awesome, right?
Yeah.
So creating a lot of safe space so that we can get the work done.
And a lot of communication, it sounds like.
Absolutely,
Yeah.
absolutely. And the communication is ongoing, right? It
Mhm.
starts the first day, building that level of trust and making sure that, like, I'm not here to fix you. I'm here to walk alongside of you and help you and guide you along the way. But ultimately, I want what you want out of this, right? So even just lending those kind of words, which is something that I think a lot of people, as clinicians, I'd say, struggle with, is the language.
Yeah.
We talk a lot about like clinical buy-in and patients not really, feeling like they're valued. I'm like, it goes back to the way that you approach it, right? I have a lot of, patients that don't look like me, that don't come from my background, who I'm able to build incredible trust with.
Mhm.
And that doesn't necessarily mean I have the hottest personality on the block, but it just means that on a professional standpoint, I understand that in order for me to lend my skills and do the work appropriately, I have to be willing to meet people where they're at.
Yeah. So a lot of what we teach with our clients is our students who are professionals is you're always kind of neuro-regulating with the client you're with. So do you have your students do anything themselves? Because sometimes almost that's once they learn how to do it, that's almost easier than explaining what you're doing to just co-regulate.
Yeah. So when I teach, I am big about, starting with you. Of
Mm.
course, I'm going to unpack your why. Why are you even here?
Hmm.
Okay. If you're here just because you got some infertility issues and you want to get fixed, this is probably not the best place for you,
Hmm.
right? But if you are here and you genuinely have a burden for this population, right, or you're seeing a lot of it and you feel very misplaced, great. Let's lead with that discomfort. I think a lot of people, and this is always so exciting because, of course, a lot of PTs and OTs are ortho, or neuro.
Hmm.
Is they are a lot of us are used to being in spaces where we are the best, the expert, on top. We know all the answers. Boom, boom. I can give it to you right away, right? And I think what is so great is being able to lead people to navigate in areas where they are not comfortable. Where I don't even know what that means. Can you explain that? Thank you for asking.
Hmm.
Let's dig into that. I'm happy that you don't know what that means, and I'm happy that you didn't just nod your head and
Yes.
act like because your patient's gonna mention that she has such and such disorder next week, and I don't want you to fake it. I want
Yeah.
you to be genuine, right? So I think that has a lot to it. I mean, and even sometimes it's even granular. Like I don't. I don't talk down to patients, like my body language. Like I'll tell a patient if I'm happen to be standing up and then they go to transition and sit down somewhere and we're talking, I'm like, hold on a second, let me get on your level, right? So I even
Mm.
prefer if they're like sitting on the table and I'm sitting on the chair, or we're sitting face to face, because teaching things like that are so, I mean, what does the study say? It's like 80 or 75% of language is, or is
Is
of
your body
communication is
language.
your body
Yeah.
language, right?
Yeah.
So that's where it starts. Is you can't even we can't, because we're infertility, reproductive problems is literally some of the deepest work in the
Yeah.
human experience. Next
Yeah.
to grief,
Yeah.
right? Next to loss, right?
And involved in grief, includes grief and
Includes.
loss. Yeah.
Exactly. It is. So you cannot go in without that level of empathy. And I also think it's important too that you're not taking that on, right?
Mm.
So it's like a
Mhm.
sense of there's a delicate balance there. It's, I have, and I admittedly would say that no matter how long I've been doing this, I do have some people that keep me up at
Mhm.
night. That, I'll wake up from out of sleep and I'm like, oh God, I gotta go look this up real quick, because
Yeah.
there's always gonna be that one or two people that just like, you are just a puzzle and I gotta figure out how to help you. But yeah, but I think it's important that as much as you are empathizing and you're present in the work, that you also have healthy patterns to just gently disassociate for the
Mm.
sake of you. Because if not, you will not have longevity in this work.
Yeah, absolutely. So why did you decide, instead of just doing this, I don't know what your job was before Triggered PT, but I would love to know why you chose to open a practice, because that's a whole
Yeah.
different skill set, and many of our students in our community are entrepreneurs, or budding, or aspiring entrepreneurs.
Yes.
So of course, this is work you could take to any women's health clinic, or, gynecologic practice. Why did you decide to open your own space?
Well, I think it's kind of obvious. Nobody even was like, what, fertility? What you gonna do?
Yeah.
And what I don't mention is that, I took a good break from outpatient care and I worked in the acute space. And it was kind of a life hack at the time. It was one helping me have a bit of a work life balance, getting me to the space to take the courses I wanted to take, but it privied me to having access to an amazing interdisciplinary team.
Mm, mhm.
I had all of these amazing doctors at my disposal, and I was constantly grabbing them in the hallway, meeting up for, I'd have lunch with them. And it privied me to learn a lot about the value of interdisciplinary medicine and, and insight to help patients. So, but I knew very clearly that in order to do this work well, I would have to be willing to build that environment, because there was nothing around it. And I mean, I live in North Texas. It's super
Mhm.
conservative here.
Mhm.
People are pretty cut and dry about what they're just. I mean, obviously things are starting to change post pandemic, but I started my practice pre pandemic, so
Mhm.
at the time it didn't feel like there was going to really be a natural way for me to establish what I felt led to do, in the context of what was present.
Right. Okay. So you really felt like how you wanted to work was a driver, and also, and we're always saying, talking about this, like creating the kind of business that serves your clients in the way they need to be served. And obviously this kind of work requires slowness, patience, space, not, three patients at a time, or even 30 minutes back to back.
Exactly. Like there's not, I mean, and even now, because obviously I'm teaching more now, so I don't do it.
Mhm.
I'm not treating every day like before, but even now, just like the things that go into it, the fact that I do have to correspond a bit more with these kind of
Mhm.
patients. There's a lot of things that I have to do, emailing them, having phone calls, advocacy, conversations, education, virtual consults. Like it integrates a lot more than your traditional practice setting.
Yeah, that's amazing. So, what would be your biggest kind of, I don't know, inspiration or recommendation to someone who's thinking, who's really interested, and, as you said, almost feels like a calling for the work of fertility, because it is such a sacred space, truly, and a space that has so much complexity, including shame and hope and family, and there's so much complexity. and, they don't live in North Texas, so they can't come work for you. So, what would be your inspiration for someone who might be interested in that field? What would be your next steps?
Yeah, so I get probably I get at least a handful of DMs asking me this question every week. So I'm pretty used to answering it. And I always tell people just start, just take the class, just jump right in. I think a lot of times PTs, especially PTs, but OTs also do this. Like they always, rehab professionals, we always want to read more articles or take a webinar or just jump right in. You would be surprised how much of this will complement the practice that you already have, right? Or the
Mhm.
practice that you already do. You're seeing the patients already. I guarantee you, like 90% of them have some level of endocrine disruption.
Yes, 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 especially post pandemic.
Listen, everybody has metabolic disorders, thyroid problems. I guarantee you, everyone has these hormonal problems. So,
Yes.
if anything, you're going to be able to lend more to the patients that you already see, right? But I'm big on just jumping right in. Like, I don't think there's a ton of value in just questioning it. When you feel led, when you feel that nudge, just go right in.
Yeah, love that. So let's change gears a bit. I think, your practice is so focused, it's so niche focused on fertility, but also pelvic pain, perinatal health, postpartum health. And we have one of the worst Black maternal
Oh,
health
yeah.
crises in the world in this country. And generally, maternal death rate is the worst among all industrial nations, I believe. And for Black maternal health, it's anywhere from 3 to 12 times as bad. So, being in that space, do you have any thoughts for how those of us who also, work with pregnant women who are Black, who are of color, who are, have less access to care, what are some of the things we need to be doing to improve this situation?
Yeah, I'm happy that we get to include this in our conversation today. I am not going to enter this thinking that everyone knows the facts and everyone understands the nuances involved. So I'm just going to try to speak from like a higher level and really break it down here.
Yeah.
So prior to the pandemic, I think it was in the Black community, I can say that there were general conversations around fears of going to the hospital, fears in interacting with the medical system, not feeling heard. We've had some stories and some incidents even pre-pandemic where individuals were left without care postpartum or were not listened to, and unfortunately that led to the loss of the life of the mother or the baby, or sometimes both, right?
Mm.
So there's a general issue that has been going on, and by the way, that is not a race problem, that is a systemic racism problem, right? So
Right.
that's a higher complexity, right? That's integrated in medical bias, from insurance payouts, reimbursements, providers you see, prenatal care. It's a very complex system. But
Yeah.
where we are, I think, where the major problem is right now, or where the major symptom, I say,
Hmm.
is right now, is the endpoint, is that are we safely seeing mothers to the other side, right?
Mm.
And the honest truth is, and I can even speak for myself when I had my son, is that even though I'm a provider, the fear of somebody's likely going to get this wrong, not because they're not good at their job or they don't know the numbers or they don't know what to do, is that they are in a society and they were raised in such a way that will not necessarily privy them to pay attention to me, right? I'll
Mm.
give you an example. I have a phenomenal OBGYN. And when I had a lot of complexities. I had my fertility journey. I had a lot of issues getting pregnant. So along the way, unfortunately, I did have infant loss. I had couple of
Mm.
miscarriages. So my OB was in 100%, like she knew my history. So about a
Hmm.
week before I had my son, I was starting to experience some borderline PTSD
Mm.
due to the infant loss that I had. And she kind of looked me in the face and she said, "I don't know if your body is going to be able to work through having this vaginal delivery. Do you trust me to have a C-section?" And I said, "Heck yeah, I
Hmm.
trust you. I feel it's right. I think this is the best decision for me." So I had a scheduled C-section, but a couple of days before I went into labor on my own.
Mm.
And this happened to be the only day that my OB was not on call, of course.
Oh no. Yes.
So I get in, of course I'm dilating. We have a family history of progressive labor. We progress pretty quick in my family. I mean, it's happening fast. I'm dilating. He's coming.
Mm.
And I'm in the hospital room, and the coverage OB comes in, and she's like, "Well, you know, you're progressing fine. We're just gonna give you some Pitocin." Like, no questions being asked, you know. And she just was like, "Yeah, I think you're gonna be okay." And I was just like, "Oh yeah, girl, what? I'm in a lot of pain right now. I don't think this is the best decision for me." So I'm here. There's a nurse in the corner seeing my husband and I's eye contact as this OB was barely even looking at me.
Mm.
And I scan over because I'm feeling a lot of pain at this point. I'm like, "Ooh, I don't know if this is going to be the best decision." But I also felt that from what they were telling me, I was too far to then
To have
a
this
C-section.
C-section. Yeah.
All of a sudden, I see this nurse. She's on her phone, Jessica, and she's like, and all of a sudden, I hear like the person on the phone, "Get her on the phone right now." She called my OB on her cell phone. And her OB, my OB gets on the phone. "I'm putting on my jacket right now, and I'm coming to the hospital. We're doing this C-section. Do you trust me?" And I said, "Yes, of course I trust you. Do you trust me to make the best decision for you?" I said, "Absolutely. You know me. She's been my OB since I was in college." So she's like, I was like, you know me. Cool. So of course we have the C-section. After the C-section, extended time was spent because I bled out. I had secondary postpartum hemorrhage, which happened after I had the last infant loss. And my body just picked up where it left off with the trauma, right? And after that, of course, I unfortunately I was not ambulatory for the first 24 hours postpartum because of the complications and the amount of blood loss. I got all these nurses coming in. "Oh my God, thank God your doctor came when she did. It would have just been a bloodbath if it was a vaginal delivery." How many people go through that, right?
A lot.
Be an example. And I think if you're a provider hearing this, I want you to think deeper about the scenario. Don't want you to think on face value, like, "Oh, good thing her OB got involved. She sounds like she has a good OB." That could be you. You could be the person.
The
But
nurse.
even the nurse that gets on the phone, because she doesn't know me from a can of rice. She doesn't know me. I've never met the lady in her life. She was a guardian angel, God bless her, right? But that could be you. You could be the person that says something about this is off. That this is a Black woman in a predominantly white hospital who have had several challenges having children, who's potentially, ready to have her first live birth. How can I insert myself in this situation to make sure that she is safe, that she feels heard, and she feels advocated for? And I think that three-pronged piece is what is missing in our healthcare system, is that a lot of Black women do not feel safe, they do not feel heard, and they do not feel advocated for.
Yeah. And I think what's amazing about that story is that having had children myself, and not everyone who works in this field did. When I first worked in this field, I didn't have children. So, there is some insight from just having that experience of giving birth. But even if you haven't, one of the things that's interesting to know, important to know, is that as educated or as strong or as fit as you might be in your regular life, when you're having a baby, you're in a very vulnerable situation.
Yes.
And same thing, I very well trusted my OB. There were some things that, like, if you had asked me the clinical data, I would have been like, I don't want you to do that. But like, we're like, whatever, 10 centimeters dilated. I have
Like,
no
I'm
epidural.
I'm like, I'm experiencing high levels of pain. I don't know where I'm in space. The science is not coming to me right now.
So you're just like, you have to have that person that you trust, because you can't actually advocate for yourself very well in that, very effectively, because you simply don't know what you're doing. You're just kind of like flowing with it. And that's in sort of the best case scenario, in my situation. And so what I would say is that as a provider, because the other thing is that many women die not exactly in childbirth, but in postpartum.
Yeah. Yeah.
So even rehab professionals, even perinatal massage therapists, even postpartum doulas, even postpartum fitness instructors and health coaches have a role here for that. And this is where I think all of our training in nervous system regulation and in intuitive medicine and in just observational skills and listening skills are the key, because that nurse just felt, as you said, something was wrong. She didn't really know, and you didn't really know. You couldn't have predicted that you were going to bleed out in the middle of that circumstance.
Yeah.
And so, let's say you had the vaginal birth and then it was an emergency. A lot of times what happens is that's the point where no one listens, where everyone's kind of like, oh, it's going to be fine. I think it's going to be okay. When if you just take faster action, when you like take action on that, or, if you're in a
Yeah.
postpartum rehab setting or you're in a fitness class and someone's blood pressure's a little high and they're feeling a little off, we don't wait and think, oh, she's strong enough to do this. She's a fit person. You're in a very vulnerable situation physically and emotionally, especially if you've also had histories of miscarriage and infant loss and infertility. That gets wrapped up in all of
Yeah.
this too.
And I think something, and I love that you lended, just to the imagery of vulnerability, because that's really a big piece of this. But what I found too is that a lot of what we see postpartum could have been discussed prenatally.
Mm,
And, I've had many patients who come to me who I've just noticed certain things about their health. Man, your blood pressure's just been all over the place your whole pregnancy. There's a condition called preeclampsia. I'm not saying you have it, but I just want you to be aware of that's something that sometimes people are prone to when they have high blood pressure. Big, big lifesaver for a lot of women, right?
yeah.
These are the signs to pay attention to. Even asking a question, are you going to have help at home when baby comes? So who's there?
Mm-hmm.
Just beyond you and hubby, or beyond you and your partner, right?
Mm-hmm.
Because we need a third eye in that room who's going to be looking out for you, right?
Yeah.
So I think that's really important. Of course, doulas play a big role, but I do see that even postpartum doulas sometimes don't have a lot of leverage.
Mm-hmm.
So I think, like you said, rightfully so, as rehab providers, we're typically the people that see them first. I can't tell you how many times I have picked up postpartum depression and postpartum anxiety. And unfortunately, I've had even a recent case of postpartum psychosis, right?
Mm-hmm.
In Black women.
Mm-hmm.
They're coming to see me because they trust Dr. Yeni and they know that she's going to keep it real. And I'm like, friend, I will say to my friend, something's off about you. Is your mom here? Can she take the baby?
Yeah.
Because I need you to go get some help. I'm going to have you go to the ER right now, right? And she's like,
Yeah.
oh, it's too much. I'm like, trust me. I don't, something in my gut saying that something about it. Sure enough, so I think it's about being able to sometimes be the voice for the voiceless. And it's not to say someone doesn't have a voice, but in the midst of such vulnerability that extends 6, 8 weeks postpartum, we still have to learn how to advocate.
Yeah. And I think that's so important that you emphasize that the vulnerability doesn't end the moment you like are not in 12 out of 10 labor pain. Like, you know, in a way,
Yeah.
it's worse six weeks
Oh,
later
yeah.
because you haven't slept that whole time.
Yes. Yes.
So I think that's really the key, is that women who appear, because when they come to the doctor's appointments, right, or the clinician appointment, they sometimes try to get dressed. They,
Yes. Hair looks clean. Looks like they had a shower. Like maybe they have a little lip gloss on. Like they look really good. Like, oh my gosh, you look great.
Yes. And that's where we have to not let our guard down as
Yeah.
professionals, as listeners, as advocates. And I think training your intuition by training your hands is one way to strengthen that skill set. And if you're in health coaching, another way to strengthen that skill set is training your listening, your mindful listening, training your neural attunement, so that if, especially when we see, in health coaching and in PT and rehab and these kinds of professions, the doctor, the gynecologist is going to see the person at the hospital. and then 6 weeks later, and then basically that's it, unless they reach out. And so we have that relationship building that you talked about in the beginning that helps to attune when things are more normal for that client and when they're a little bit off. And I think it's another thing is to start adding, perinatally, prenatally, postpartum, basic things like blood pressure, like hydration, like pain, bleeding, don't just dismiss some of those things out of hand.
Yeah. And obviously there's pretty easy to use objective tools out there that we can, build into our paperwork. I mean, all of my patients get a DAS survey I think they get it every 2 months,
Mhm.
So I'm getting an update on, their anxiety and their depression, and we're talking about it. I'm like, hey, I noticed there your score dropped. Let's lean into that. What's going on with you? And I think something that I also want to mention is just like also this that post pandemic change too in Black maternal health, because we did see that a lot of women, Black women especially, left traditional forms of medicine
Mm.
and went to midwifery support, doula support, and are looking to do more home births or birth center births. And conversation that I had a lot with a lot of my colleagues, and especially a lot of women of color who are providers. A lot of the conversations I've had is, okay, are we still screening these women for their high risk, right?
Mm.
Because sometimes they're not aware that they're high risk. Because unfortunately, when you are a Black woman birthing in America, you're high risk. That's the
Mm.
honest truth, right?
Right.
And then add the age, and
Hmm.
then add some of the complexities and comorbidities, right? So I'm saying, are we still having that conversation? Are we screening them appropriately, making sure that this person is even safe to have a home birth, right? Or safe enough to have a birth at the birthing center, right? And so I think sometimes it's tough when, especially I think it was probably around 2021 was when I found that I would have patients that would damn near have like mental breakdowns in my office when I say, I think you need to go see an MFM, because I think you're 38, this is your first kid, you've had some weird nights, and
Hmm.
I'm not feeling comfortable with the fact that all you're seeing is a midwife. I'm not
Right.
saying your midwife isn't great, but not all states have the same regulations for midwives, right? So there's some states that midwives are trained differently than others, and there can be a lot of inconsistencies in the cares that they're delivering. So in Texas, though, out of all the states, we have the worst Black maternal outcomes
Mm.
out of the United States.
That's terrible. I
It's
mean,
awful. It's
yeah.
the wild, wild west out here, literally. And it puts a incredible burden on allied health professionals, on birth providers to know more, to do more.
Well, and unfortunately, that's probably going to get worse
Mm,
because we're now in a situation where, we saw that recent case in Texas where, essentially they're telling women who need abortion care to wait in the parking lot until they're septic and then they can treat them. This to me is so problematic, not just because of those acute cases, which apparently
yeah,
there's
yeah,
something on the order, that was in the news. There was a lot of talk about this, but I've heard the data is roughly 90,000 cases in that state since Roe v. Wade was overturned. So in the state of Texas, 90,000 similar cases. And then the other problem, though, is that gynecologists are not coming to Texas to train.
yeah, yeah.
And
But
so,
can you blame them
oh,
though,
no, no.
Jessica?
I mean, I certainly,
Absolutely
yeah,
not. I cannot blame them
no.
because, and that's where, I mean, I'm not saying, of course, in the state of Texas, we do have great providers, but
Oh, for sure.
I,
Yeah.
I think in the coming decades, if we do not see a change on the legal side, you're going to see less and less high quality providers who want to practice here, right? Because the limitations are much.
Well,
There
and it's
should be no
dangerous
reason.
for them,
Yeah,
really.
yeah. And of course, if you have a patient that has a trisomy, genetic disorder, and they're carrying a child, and they're looking to get a early enough abortion, and they're not able to do that,
Hmm.
this is just messy, right? So I think it's interesting that you brought this up, because a lot of times people don't think about the whole abortion conversation in the context
Of
maternal
fertility.
health,
Yeah.
of fertility, right? But it's all reproductive care. It's all the same thing, right? It all falls under, because you and I, maybe because of the kind of work that we do see the anomalies and the inconsistencies in care. So I'm like, they do exist, guys. It's not always just somebody got knocked up and they want to make this decision, right? It's usually severe medical decisions being made, right? Or and if people don't have the options, then we do see more mortality, unfortunately.
Absolutely. And if you lose, high risk gynecologists, people who are trained surgically in high risk gynecology, then, and I agree with you completely. I gave birth actually to both of my daughters in the state of Texas. I worked
Oh,
for off and on for about a decade at the Women's Hospital of Texas in Houston.
in Houston, yeah.
Great maternal care. We delivered on average one baby an hour the whole time I worked
I believe
there.
it. I believe it. I'm pretty sure it's still the same.
Yeah. So we saw everything. I worked with women in labor and delivery and postpartum and outpatient, and, had both my daughters there and had a miscarriage there. And so I've experienced that among wonderful providers in the state of Texas. And I also know midwives because I used to, send patients back and forth to midwives, some of which were
Yeah.
very skilled. So I think, as you're saying, the gamut of professionals, there are great professionals in Texas and in all states. And when you create an environment, not just in Texas, but in, other states that have these issues, Tennessee is another one, um, it becomes difficult because then more women. So what you're saying is already the pandemic sort of drove more Black women to seek care from midwifery and home birthing, which
Yeah.
for certain people, that's a really good option. But we are now missing some data points. We're also potentially missing some women getting the high risk care that they might need. And so I think as a profession, we need to be really thinking about that level of complexity because we're talking to professionals now. We're not just talking about, the ideal situation.
Oh yeah. Oh yeah. Because there's nothing ideal about this. Even the environment we're practicing is not ideal, right?
Yeah.
But I will say this is that I think that the solution to the Black maternal crisis in the United States is going to be multifaceted.
Hmm.
There are going to have to be a lot of legal decisions made to even give healthcare providers the environment to practice good medicine. That's the
Hmm.
honest truth. We know that
Hmm.
nurses are overworked.
Hmm.
We know that oftentimes hospitalists and providers are underpaid. So we're aware that those systemic issues are also contributing to this as well. But what we can say is that conversations like this at least will start to sow better seeds of societal mindsets, right? And restrictive thinking patterns, right? Then there's also the conversation about even in education, educating providers early on when they're in med school, when they're in midwifery school, PT school, and learning about racial bias early on,
Hmm.
so that that is woven as you're learning about physiology and anatomy, that is woven into your education and you're seeing things the way they're supposed to be seen, right? Because the
Yeah.
honest truth is, and I can share the sentiment with a lot of providers, is that most providers of color, especially Black providers, do not have the bandwidth to educate their colleagues, right?
Yeah.
So a lot of the educating really needs to be self-started. It needs to be done in forums like this because it is so exhaustive to have to be the person receiving the insult and also for, being able to communicate the solutions.
Right. It's ultimately not your responsibility to create the solutions. And I think that's where it, as you said, integrating it within our initial training is so important because so much of this bias is just subconscious. It's part
Mm,
of the training. I mean, part of growing up in a racist society. I think many people are even unaware of their own racial bias
yeah, yeah, yeah.
because it's just there, it just exists. And so we have to actively learn and be aware. So if you are in a circumstance where you're working with a woman of color who is pregnant, almost go that extra mile of looking for you know you may not be aware of your own level of racial bias. It may be very difficult to even uncover that. So try to, at some level, overcompensate, be even more focused, be just mindful. Like you said, just build it into your paperwork. Blood pressure, mental health screens, empowerment of communication to maybe her partner or other people, her doula, people who will be in the room, to give them that green light. Sometimes if a healthcare provider says like, hey, if you feel something's off, just keep
Yeah,
bothering them until they listen to you, because
exactly.
she's not going to be able to do that in a vulnerable
Yeah.
situation.
And sometimes being that provider that also kind of helps patients feel safe enough to make the right decision. I'll quickly share this story. I had a patient who had a cesarean delivery for her first child, and it did not. That's not what she wanted. She wanted a home birth. She hired
Mhm.
a whole team,
Mm,
midwife, had a doula, and everything. And so by the time she was coming to see me, it was postpartum, her first child.
mm,
So of course, after assessing the situation, she said she was fine with the C-section. She was okay that it had to happen. She'd been laboring for days. First thing I thought to myself was like, you are not the right candidate for this. You
mm,
should have probably been under the care of an OBGYN, and you need to be in a hospital
mm.
just because of the way her progression was during labor. So I had a conversation with her. I said, here are some names. So look at these providers. I'm going to give you the autonomy, of course. Do whatever decision you want, but I firmly believe. So thankfully she did. She gets pregnant again. We had an awesome VBAC experience with an OBGYN. Very affirmed, very awesome. She's now a third. She comes to me the third time with a
Mhm,
third kiddo. We've been together a while,
mhm.
and she's like, "I'm pregnant again, Dr. Yenny. What do you think we should do?" I think we should do exactly what we did last time. I think we did really well. This pregnancy was unfortunately a lot more challenging for her, and of course, there were some mental health disturbances. We worked through all of that. But one of the things I remember, she was about maybe 37 and a half weeks. She came to see me, and I was like, and her blood pressure was in the 160s. She was in the ER 2 days before, it was in the 180s.
Mm.
It was all over the place. And I looked at her and I said, I think we need to have this baby. And she goes, well, my doctor is saying maybe I should wait another week and a half. And I said, I really think you should have this baby. So I get on the phone and I call the doctor's office and I say, she's in my office. I've taken her blood pressure. I don't love the way she's feeling.
Yeah.
And I know her. And I genuinely feel that she needs to come in and get induced.
Mhm.
And she's like, it's the nurse practitioner. So she's like, hold on 1 minute. And she comes back and she's like, okay, the doctor says she should come in. And I looked at my patient because she was crying. She was very emotional. I said,
Yeah.
you got this. I said, I have a strong feeling you're going to have this baby tomorrow. So it's going to be a long night. So go stop by and get you some French fries or something.
Right.
We live in Texas, so get you some Whataburger
Right, right.
and and fuel up because you're gonna have a long night ahead of you because I have a strong feeling you're gonna have this baby tomorrow. And
Mhm.
sure enough, she texted me, I did it. I can't believe I got my second V back. It went well. Again, all you had to do was lean in and trust that
Yeah.
instinct. A lot of us are, even if we're not moms, we have that feminine energy, that feminine grace in us, that instinct where we know like when something's off, that intuition that tells us a little bit inside of us that something about this isn't right.
Yeah, I love that story. And the one other thing I'd like to emphasize from that is you have done the work of building these relationships
Mm,
with your clients, but also with the local physicians, nurse
yeah,
practitioners, midwives. People used to ask me all the time when I was at Women's Hospital, I used to call the doctors all the time because we
yeah,
worked with them. We were very connected.
yeah.
Um, one of them delivered a couple of my own babies. I fixed her shoulder. Like there was a lot of,
It's the whole thing.
yeah. So I think, and I do think that relationship building takes away some of the other structural problem that we have in hospitals, which is that kind of structural hierarchy where people feel, intimidated to call a doctor, to call an OB nurse, to
Yeah,
call a midwife. And I think having that confidence to develop the relationships is a part of your advocacy for your most vulnerable clients and patients. So as soon as you can start developing those relationships, just meet these doctors, just meet them. They're all normal
Yeah.
humans.
They
And
really are. They have the same, they probably are fighting with your toddlers the same way you are. They're
yes.
sleep deprived the way you are. I mean, it's just like we're all human. I love that you said that. It does take time to build the relationships. It does take time to build that reputational integrity in your community,
Yeah.
but it's so worth it. It makes your job so much easier when you can be direct and you can advocate for your patients because the provider actually knows you or at least have heard of you,
Yeah.
and can feel like, okay, I think this person knows what she's talking about.
Yeah. And I think when you build your practice, we kind of just to circle back to end this at the beginning where we started, if this is a passion, a professional passion for you, a calling, just something you're super interested in and curious about, and you want to create that space in your community, if you think of this as a long term commitment to your community, to the perinatal and women struggling with fertility in your community, and building those relationships, meeting the people you need to meet in your community, you'll ultimately, have the opportunity to create the kind of practice that you've created.
Yeah.
And I would imagine it's very rewarding.
Oh yeah, absolutely. It is very rewarding and it definitely keeps you going, especially on the days when being a business owner gets hard. And of course, there's all that stuff to it. But I definitely think even conversations like this just make you really reflect on how much of a just a privilege it is for us to be in this space,
Yeah.
and get to walk with people in the most vulnerable times of their lives. So yeah,
Absolutely. Well, thank you so, so much for spending so much time with us today.
no worries.
And share with us how our professionals can find you if they're interested in doing more of your training.
Yeah, so for all professionals, I recommend that you check out triggeredacademy.com. We're also on social media, but the real people know that all the love goes into the newsletters and the mailing list. So
Mhm.
feel free to just contact us at triggeredacademy.com. And I've got a great team that helps me out over there to communicate. So if you ever have questions about the courses, we've got master classes, we've got a certification we're running right now. I'd love to pour into you and help build that side of your practice up if fertility and gynecological care sounds interesting to you.
Yes, excellent. Well, thank you so, so much. I'm so glad to just hang out with you a little bit more today and
Same. It's so good to see you
see
again,
you soon in
Jessica.
Atlanta.
Yes,
Yeah.
we'll do it again. Thank you so
Perfect. All
much.
right.
All
Thank
right.
you.